Hey guys, how are you all? Welcome back to MedSteps YouTube channel. You are watching episode 12 in our first aid series, and today we are diving into Lumbosacral Plexus part 2 because we already in our previous video we discussed little amount of Lumbosacral Plexus. It's too many nerves we can see in lower extremities, so that's why I don't want to make like too much long video, so that's why I'm dividing into two parts. Okay, so in this video we will build on the foundation from part 1 and take a deeper look at the clinical anatomy now and pathways and key high yield concepts you need to master for FMGE and NEET PG examinations. So grab your notes and let's get started. So guys, in our previous video we studied something, we discussed a little amount of lumbosacral plexus. So just I'm going to give little brief what are the things we discussed before. First one, I told something about introduction of lumbosacral plexus, and we understood we understand the divisions of this anterior division and posterior division of lumbosacral plexus, and we discussed a little amount of upper plexus we call lumbar portion, and lower plexus, and we from sacral portion like L4 to S3, and we studied something about like functional things and advanced clinical scenario. Also we discussed little amount of clinical conditions, and mostly like lumbosacral plexus, lumbar plexus and sacral plexus we divided, and we went like deep to the every nerve like subcostal nerve. We discussed what are the clinical relevance of the subcostal nerve and iliohypogastric nerve and some amount of ilioinguinal nerve. We discussed everything like motor, sensory, injury, and what are the clinical features presents with patient will present with what are the clinical features, and we discussed little amount of genitofemoral nerve and lateral femoral cutaneous nerve and femoral nerve and obturator nerve and some amount of sacral plexus. Okay, so these are the things we already discussed. So today, so in this video, and we compared with little amount of obturator nerve and femoral nerve we compared also, and now in this video we are going to discuss about common peroneal nerve and some other nerves also we are going to cover. Okay, so first one, common peroneal nerve is a branch of sciatic nerve. Okay, common peroneal nerve is a branch of sciatic nerve. Good. So if you are seeing this line here, the sciatic nerve branches into common peroneal nerve and tibial nerve posterior in the thigh just proximal to the popliteal fossa, where you can see popliteal fossa. So this is the area of popliteal fossa. In this popliteal fossa we can see here the common peroneal nerve arises from the sciatic nerve. So this is the sciatic nerve. From here we can see it's dividing into two parts. In that part we can see this is common peroneal nerve. Then after the common peroneal nerve and we can see like some tibial nerve. You can see here this is the tibial nerve. Okay, why we have to discuss this common peroneal nerve, fibular nerve means because if any patient coming to you with foot drop, then you have to suspect that patient commonly injured nerve will be like common peroneal nerve. Because of that common peroneal injury, the patient results with foot drop. Okay, that's why we have to know everything that origin and that course and how it will divide and what are the functions, everything you have to know. That's why I'm going little deep in this topic. Okay, and this is very important topic because in my clinical rotation I saw more than 10 foot drops. Okay, because of fibular fracture and these things we will discuss step by step. So now the sciatica nerve splits into tibial and common peroneal nerve just proximal to the popliteal fossa, just proximal to the popliteal fossa. The common peroneal nerve travels laterally around the neck of the fibula. If you are seeing here this image, you can see here the peroneal nerve, the common peroneal nerve is going to down and it travels laterally around the neck of the fibula, and it's making it highly vulnerable trauma. If any fracture happen here, the patient will get the foot drop, okay, because the fibular neck fracture will happens means any trauma happens means that time that the common peroneal nerve will get injury. So how it will divide that common peroneal nerve divides into superficial peroneal nerve and deep peroneal nerve. Okay, in second image, these are the image. This is the common peroneal nerve is going to anteriorly. So from anteriorly, the common peroneal nerve divided into two parts. Here this one and this one. Here we can see deep peroneal nerve. Mostly we can see this thing in anterior compartment, where we can see anterior compartment of the knee. Next one, superficial peroneal nerve. The superficial peroneal nerve will be we can see in lateral compartment of knee. Okay, lateral compartment of the leg, sorry. Now here we have one mnemonic, that mnemonic we call PED. If any patient getting common peroneal injury, what problem they will get? Foot dropped. Okay, if this foot dropped, you can divide here this PED and you can, this is a mnemonic PED. P means peroneal, E means eversion of the ankle, plus D means dorsiflexion of the ankle, dorsiflexion of the ankle. Okay, so in motor innervation we can see like this deep peroneal nerve. In motor function, in deep peroneal nerve, in motor function we can see like that it innervates to the anterior compartment. In anterior compartment, there's some muscles, 4 muscles we can see like tibialis anterior, extensor hallucis longus, extensor digitorum longus, and fibularis tertius. Okay, this muscles action will be dorsiflexion of foot and toes. Next one, superficial peroneal nerve. That means this nerve. That superficial peroneal nerve innervates lateral compartment. We already discussed this thing. And in lateral compartment we can see 2 muscles, that is fibularis longus and fibularis brevis. This muscle is main function for eversion of foot. So now sensory innervation of common peroneal nerve. Then common peroneal nerve, mostly we can see superficial peroneal nerve, and it will that sensation we can see in dorsum of foot except first webbed space, and second one deep peroneal nerve will be like web space between first and second toes. So before going to common peroneal neuropathy, this is the pathological condition of the common peroneal nerve injury. Before that we have to understand the mechanism of injury of the common peroneal nerve. Here what are the mechanisms we can see here means because it winds superficially around the fibular neck. This is the superficial and it surrounds the fibular neck. We can see this now. The common peroneal nerve is easily injured by fibular neck fracture. If any patient got fibular neck fracture, that person can get this common peroneal nerve injury. And leg cast compression. If any person getting cast, it's too much tight, because of that compression can cause here you can see here, this is the, if any person getting leg cast compression, that nerve will get compressed. It's very close. Fibular prolonged squatting also, you can see this image. He can this person is in squatting position, so that's a prolonged squatting or leg crossing and knee dislocation or surgeries can cause this common peroneal neuropathy or common peroneal nerve injury. So what are the clinical presentations we can see in this type of patients means, here you can see here common peroneal neuropathy results in like foot drop, Okay, and why foot drop? Because of the deep common deep peroneal nerve injury, deep peroneal injury, deep peroneal nerve got injury. So because of that we can see loss of dorsiflexion and foot inversion predominance. Because of aortas are weak, superficial branch will be like because of that injury we can see the that eversion movement will be ankle eversion movement will be like very weak, and we can see sometimes steppage gait and sometimes sensory loss also, like dorsum of the foot except up space and deep, and lateral shin and calf also. Okay, so we can see the sensory loss in lateral shin and calf area. Why? Because these nerves are passing in ankle area. Okay, this is very important. Okay, so if in this is the sensory innervation, in this sensory innervation we can see impaired sensation and impaired ankle dorsiflexion, foot drop at toe and toe extension. Okay, clinical cause, we have to ask the patient, do you trip on stairs or do you feel numbness on the top? We have to ask any the patient is feeling any numbness on the top of your foot, like that we have to ask, and we have to observe the gait, and we have to observe the like any patient have any steppage gait, like that we have to think. Okay, now so these are the things we have to ask from patient. Okay, you can see here this is the sural nerve and tibial nerve and common peroneal nerve. This is the dorsum of foot, and this is the deep peroneal nerve inner sensory thing. Here if any patient got like fibular neck fracture, that patient is very prone to get foot drop and common peroneal nerve injury. Okay, mostly doctors will tell like common peroneal nerve injury, but we have to think about deep peroneal nerve and superficial peroneal nerve based on compartments. Okay, so next we are going to see the tibial nerve. In this tibial nerve, what is the main important things? Means in tibial nerve we can see here the tibial nerve is large medial branch of sciatic nerve that descends through the popliteal fossa together with the popliteal vein and artery. So in motor innervation we can see like posterior compartment, and in posterior compartment what are the muscles we can see, like gastrocnemius, soleus and gastrocnemius and soleus, and flexor digitorum longus, tibialis posterior, and the action will be like plantar flexion and inversion. The sensory thing will be like plantar foot. You can see here this is the plantar foot place, and we can see the heel, and we have sural nerve. Here this part we can see like innervated by sural nerve. This is very important. Okay, don't confuse it with sciatic nerve and sural nerve. Okay, and here for this tibial nerve we can check with Eckel's reflex. Okay, so main motor function will be like in tibial nerve. Okay, don't confuse with common peroneal nerve and the tibial nerve, because we can see here that common peroneal nerve branch is sciatic nerve, and tibial nerve that branch of sciatic nerve. Okay, same to same. Common peroneal nerve will division location we can see in popliteal fossa, tibial nerve division location also popliteal fossa, and common peroneal nerve motor function will be dorsiflexion and eversion. The tibial nerve motor function will be like plantar flexion and toe flexion. In sensory distribution we can see common peroneal nerve will be like dorsum of foot, in tibial nerve we can see sole of foot. The common peroneal nerve, if injured means it leads to foot drop. The tibial nerve, if it's very injury, leads to inability to stand on toes. Okay, so these are the things we have to mostly we have to focus and we have to understand. Okay, so next one. Now in tibial nerve, what are the mostly we can see how that patient will get mechanism of mostly how that patient will get injury means, if patient like proximal lesions, knee trauma or Baker cyst. In distal lesions we can see tarsal tunnel syndrome. And another thing, less frequently injured with like causes will be like, this is the main important things. Okay, so this is, we have one mnemonic, that is tip. If injured can't stand on tiptoes, to tip means TIP, T means tibial inwards and P means plantar flexus. Okay, so this is the very important. So in clinical presentation, we can see tibial nerve motor will be like weak plantar flexion and weak toe flexion. In foot posture we can see like dorsiflexed and everted, and we can see gait, it's like difficulty walking on toes, and we can see like sensory loss like sole of the foot. And if you are checking like reflex, that patient if you are checking the reflex, we can't, that patient like the Eccles tendon reflex S1 and S2 is mediated by the tibial nerve, and loss of the reflex suggests tibial nerve or S1 S2 root lesions. So reflex testing will be when Eccles tendon reflex will be decreased. Okay. In imaging, how we can differentiate? For tibial nerve descending straight down to the posterior leg. Okay, so mostly this tibial nerve is associated like I already told gastrocnemius and these muscles. Okay, so in clinically we can see like if any patient getting loss of plantar sensation, then we have to think about tibial nerve. If patient is not getting walk, is very inability to walk on toes, then tibial nerve. If patient getting foot drop, then we have to think common peroneal nerve. If patient getting like steppage gait, then we have to think about like peroneal palsy. Okay, this is the things is very important. Next, if in tibial nerve injured by mostly posterior dislocation or trauma, and foot position will be a dorsiflexion and everted, the reflex mostly affected in Eccles reflex, and gait will be like difficulty to toe walking. Okay, so next one, I already covered this everything, dorsiflexion, numbness of the calf. Yeah, next one, superior gluteal nerve. The superior gluteal nerve is originating from the superior gluteal nerve, mostly we can see in, it's originating from which nerve? It's like it's that origin will be like L4, L5 and S1. The superior gluteal nerve is like very it's very easily you can remember, because it's that motor function only we can mostly we are going to focus, that is gluteus medius and gluteus minimus, and sometimes you can select on gluteus minimus and tensor fascia lata. Okay, that functions will be like hip abduction and pelvis stabilization. So this is the main function of the superior gluteal nerve. If any lesions causes like iatrogenic injury during intramuscular injection to the upper medial quadrant of the gluteal region, then that time that patient will get supralateral quadrant buttocks is relatively safe site for intergluteal injections. If you are seeing this image, you can see here the superior gluteal nerve is coming or is going up. If any person giving injection close to superior gluteal nerve, that nerve will get lesion, and that person will get problem with that pain, and it can lead to piriformis syndrome also. Okay, so that's why we have to always, when we are giving injection, we have to avoid the we have to avoid these things. So always inject the superior means upper region and lateral. Very easy. We have to divide the buttocks into 4 parts like this. Okay, 4 square boxes. Then after we have to go and we have to do injection on superior lateral quadrant. Okay, this is superior and lateral and quadrant. In quadrant we have to give exactly in glute we have to give injection, because if any person got injections, if any person did injection in like superior medial or superior medial quadrant, that patient is very prone to get superior gluteal nerve injury. This injury causes mostly Trendelenburg gait. If you are seeing this image, this is proper placement of the nerves. Okay, so here if any patient got a Trendelenburg sign, that hip will get dropped and observed contralaterally. We have to observe while walking. We can see the superior gluteal nerve, that gluteus medius weakness and minimus cannot be contract. Why? Because of that nerve. That nerve is not passing the sensation to the gluteus medius muscle and minimus muscle. So this is the main important for the abduction of the hip. Okay, and this muscle is very important for hip stabilization. If any injury or any lesion happen here, then the patient we can see like Trendelenburg gait, that pelvis will drops on the contralateral side of the raised foot, and the test will be, if you are telling like the patient have to stand on one leg, the pelvis will drop on the unsupported side. Okay, so that's why this is very important. So that high yield in exam, what are the things they can pick? Means the superior gluteal will be like abduction, and mostly for pelvic stabilization it will help. Okay, so next, here this superior gluteal nerve, I already told this L4 and S1 mostly we can see it's a motor only, and it innervates the gluteus medius, minimus and transverse facility, everything we discussed. And next, if you are going to, if you are seeing this image, you can see here this is the Trendelenburg sign. Okay, so if we are telling to stand on one leg, the patient will get very difficulty to stand, because of normal the gluteus medius and minimus contract to keep the pelvis level. Okay, because of lesions the patient will get this one side unaffected side, the patient will get drops. Okay, so mnemonic will be standing, hip drops on opposite contralateral side. While walking, patient lean towards same ipsilateral side. Okay, so these are the things you have to know. So mostly I discussed everything. Next we are going to see the inferior gluteal nerve. In this inferior gluteal nerve, mostly we can see like it's innervated by this inferior gluteal nerve. Most origin will be like L5 to S1 S2. That innervation will be like gluteus maximus and hip extension. This thing happens because of posterior hip dislocation, like dashboard injury. If any person got dashboard injury, like car drive with injury with the car, that time you can see this type of inferior gluteal nerve lesions. Okay, and presentation will be like loss of hip extension and difficulty with climbing stairs, rising from the seated position. Okay, so these are the things about inferior gluteal nerve. Okay, now we are going to see the pudendal nerve, very important nerve and very high yield topic. So now we have to focus more in this part. Okay, this pudendal nerve, we have to understand the pudendal nerve. Pudendal name is like psi. Okay, phi means okay. Now we are going to explore the pudendal nerve. It is derived from S2, S3 and S4 of the spinal roots. It's often remembered. We have one mnemonic that is we have one mnemonic that is S2, S3, S4 keeps the poop, P and penis off the floor. Because this S2, S3, S4, this S2 we can see like it will keeps the poop, and S3 will be like P and S4 will be like penis of the floor, that sensations and everything we will discuss in deep. Okay, the pudendal nerve exits the greater sciatica forearm. The pudendal nerve mostly it exits the greater sciatic foramen. We have one sciatic foramen. From that foramen, that greater the pudendal nerve will exit, and it curves around the ischial spine. You can see here, this is the pudendal nerve. Okay, that pudendal nerve is exits from the sciatic foramen and it curves around the ischial spine. If you are seeing here, this is the ischial spine. From ischial spine it's like curved, okay, around the ischial spine and re-enters through the lesser sciatic foramen into the perineum. It travels within the Allox canal, that is pudendal canal. We call Allox canal or pudendal canal. Okay. Here what will happen? It's very important, so I am mentioning here. Alcox canal or pudendal canal also you can tell. Alcox. Okay. So for pudendal now, the motor innervation will be, it's like the structures, it's that pudendal nerve is mostly structures that motor innervation I am going to tell now. In motor innervation mostly we can see the structure supplied by like external urethral sphincter, external anal sphincter and perineal muscles. Okay. So mostly we can see like voluntary control over urination and defecation, and in sensory innervation we can say like perineum including genitalia and anal area and lower vagina and lower labia and scrotum. These are the things supplied by this pudendal nerve. Okay. In functions will be like that's mostly we can see sensation to the external genitalia and perianal skin. Okay, the clinical relevance will be like childbirth injury, like the pudendal nerve is at risk during childbirth because due to overstretching as the baby passes through the birth canal. Why? If any baby have like mother got while pregnancy, while gravid mother have gestational diabetes, in that because of that gestational diabetes, that child fetus baby will get too much fat. Because of that fat we can see macrosomia. That macrosomia can cause overstretch of the birth canal. Okay. So because of that birth canal we can see decreasing sensation in perineum and genitalia and urinary fecal incontinence and loss of anal wink reflexes. Okay. So this pudendal nerve basic concept will be like in labor time we can give like analgesia. We can that time we can block the pudendal nerve using a local anesthetic to reduce the perineal pain. If you are seeing here, you can see this image. Here this physician is holding the perineal nerve. The physician is holding pudendal nerve and is giving anesthesia or local anesthesia or labor analgesia is given to perineal is given to pudendal nerve for decreasing pain, for decreasing the perineal pain. Okay. So during childbirth, the pudendal nerve block advanced technique, how we can give that pudendal nerve block means the technique will be the ischial spine is the landmark. Okay, this is the ischial spine. This is the landmark for giving pudendal nerve block. How? For pudendal nerve block, the nerve runs medial to the ischial spine. It's not lateral, it's medial to the ischial spine, and then after just behind the sacrospinous ligament. Okay, this is the, you can see here, this is the sacrospinous ligament. Behind the sacrospinous ligament we can see the in medial to the ischial spine. Okay, the procedure will be like we have to perform this thing in transvaginally and we have to use the ischial spine as a bony landmark. Okay, and we have to insert towards the sacrospinous ligament. We have to insert the needle where the pudendal nerve lies. The mnemonic will be the pudendal nerve runs just posterior to the spine, so aim for the spine to numb the line. Okay, this is the mnemonic. So in clinical case teaching we can in clinical case we can say like we have to imagine a postpartum woman complaining of loss of perineal sensation. That time we have to think about involuntary patient getting like involuntary urination or defecation, and that time what we can suspect, what we have to suspect means pudendal nerve injury during delivery. Okay, so In anatomically some landmarks is very important, so now I am going to discuss that landmarks. Why? These are the very prone to get this is very easily that examiner can ask this type of questions in USMLE and FMGE, these things. Like pudendal nerve will be like, the landmark will be like ischial spine and sacrospinous ligament. Next one, ischial spine, we can see like landmark for nerve block. Okay, so these are the things we today we discussed about a common peroneal nerve injury. Okay, some anatomy, origin, motor function, sensory function, clinical relevance, everything in every nerve we discussed. Okay, common peroneal nerve injury we discussed, tibial nerve and superior gluteal nerve, inferior gluteal nerve, then after pudendal nerve, everything we discussed. So here one small one nerve is very important, so I am planning so I am going to give one recap, that is S2, S3, S4. Origin will be like pudendal nerve that keeps poop and pee off the floor. This is the mnemonic. Pudendal nerve block landmark will be like ischial spine. If injured, we can see like perineal numbness and incontinence and defecation and these things. Okay, so if you think this video is very useful for you, like, share and subscribe. Take care. Bye bye. We will meet in our next episode, that is episode 13. We are going to discuss about avascular necrosis. Okay, take care. Bye bye.